Thank you all for joining us today. This is the first of our campus speaker tea lunches that we're going to have as part of the Women's Empowerment Initiative. My name's Mandy Mount. I'm the chair of the Women's Empowerment Initiative. And for those of you who may not have heard of the initiative yet, that's because it's new. So if this is your first event with us, welcome. And some of you may have also joined us for our earlier event with Dr. Jean Houston. How many of you were able to attend that event? Wonderful. Welcome back. It's great to see you, and it's wonderful to have all of the new faces with us as well. For those of you who are new, I just want to tell you a little bit about the Women's Empowerment Initiative and where we've been and where we're going. So we did start with our launch this past November. Dr. Jean Houston joined our campus for a couple of intimate conversations as well as a larger community event. But the Women's Empowerment Initiative is much broader than these speaking engagements. It's intended to have various components, including research, scholarship, educational opportunities, and summer institutes for girls. So I want to draw your attention to the cards in the center of your table. If you are interested in getting on a list for these events in the future, please just go ahead and fill that out and let us know who you are. You can leave it there on the table. We'll collect them afterwards. There's also many other opportunities to get involved that are listed there. Let us know how you would like to be involved. Our vision is that the Women's Empowerment Initiative will continue to grow and be a presence on the UC Irvine campus as well as other campuses. Before I introduce our speaker today, just a couple of housekeeping things. We are going to we're going to have this event all the way up until 1:30 today. There's going to be some time for networking and community building and sharing of ideas after Allyson is done speaking with us. So I invite you to stay, enjoy a cup of tea, enjoy the rest of the snacks that were provided for you, and get to know one another, because that's so important when we are talking about empowering women, that we have that opportunity to connect around these ideas and make that work happen. And that's actually the reason that we're gathering today over tea instead of the typical brown bag lunch that we're so used to. And so I wanted to just share a couple of things with you about tea that I've come to learn in the last few months, because I've come to learn that tea serves a very important purpose in many communities around the world. In Asia, for example, tea houses serve as a meeting place for socialization, for intellectual stimulation and relationship building. In the afternoons, the tea houses are filled with students and business people. In the evenings, they cater to night owls who are searching for something to do. In Japan, many businesses give green tea during meetings or on breaks, and that green tea is shared with treats that employees bring for one another from business trips or from vacations. Tea is also prepared for visitors in business meetings or guests in one's home in Japan. In England, we're familiar with the English tea. It looks something like what we have here, right? The formal tea. But it's also something that's enjoyed by the majority of people in England on a daily basis. It's a very important part of socialization and an important staple in their society. In Burma, you might not know that their street culture is actually more of a tea culture. People spend time in tea shops, reading the paper, having conversations with friends. And while they exchange the news and gossip and jokes, people nurse cups of Indian tea while they're enjoying a diverse range of snacks such as cream cakes and steamed buns. The examples go on and on. There are many, many cultures that build community around tea, as we're doing today, but the message is the same. Around a cup of tea, people can come together and share in social interaction, igniting the sharing of ideas and the meeting of minds and spirits. I hope that you will find this space to be a place where minds and spirits can connect around issues that are very important to all of us. I hope we will draw inspiration from the messages that we hear today and take advantage of this space to build and grow out of what moves us. Each of our tea lunches will feature ideas of relevance to the growing role of women in this world, designed to challenge our thoughts, engage our interest, and provide direction for growth. So I invite you to stay after the presentation to take advantage of that opportunity. And we're very, very fortunate today to have Allyson Sonenshine be our first speaker for the Campus Speaker Series, as part of the Women's Empowerment Initiative. I was really happy when she said yes when I invited her to do this, because she has spent an inordinate amount of time trying to understand the impact of the ACA on women's health issues, and has spent over 20 years in women's health and reproductive rights work. So she's very, very knowledgeable, and she's also the reason that my mother now has health insurance this year. So thank you, Allyson. To tell you a little bit more about her, she's also the founding project director of the Orange County Women's Health Project. This is a nonprofit that identifies gaps and facilitates improvements in local women's health. And she also oversees the Orange County Women's Health Policy Summit, which annually brings stakeholders together around the community. She's a recipient of the Breaking the Glass Ceiling Award from the National Women's Political Caucus, Orange County, and she was recognized as a 2013 Woman to Watch in OC Metro Magazine. So she's very accomplished, and I invite you to join me in welcoming Allyson Sonenshine.
First of all, I'd like to thank all of you for being here today to help kick off the Women's Empowerment Initiative. I'm so grateful that UC Irvine had the foresight to put together such an ambitious and important initiative across campus. I think it's wonderful to bring together faculty, staff, students, and active individuals in the campus around the issue of women. And I'd like to particularly thank Mandy Mount from the CARE Office and the Office of Student Affairs. So thank you very much for helping to hopefully launch a little history here. Before we begin, I would like to ask a little bit about you, the audience. It's not really fair, you know all about me now, and I know nothing about you. So first tell me, raise your hand please, if you are faculty, staff, students. Great, that's a terrific mix. And visitors. Well, that's exactly what we hope to achieve with this initiative, so I'm pleased to see we're off to a great start. And I have one other question for you. What do you think is the significance of this number, 1,389? I had to ask Siri for help this morning. Just call out, just take a guess.
Email.
Emails? That would be way too low, right? 1,389 is the number of days since the Affordable Care Act was signed into law. March 23rd, 2010. So although we've been living through the rollout in the last few months, this law has been with us for well over 3 years. And we've got a long way to go. And it's awfully frustrating right now to try and understand how to live with it and make it work for all of us. But my objective today is to make sure that everyone in this room understands and hopefully appreciates why there is so much to be excited about in the Affordable Care Act for women, and in particular improving women's health. So that is the overarching objective for my talk today. And I see that you all have a printout, so feel free to mark it up, but hopefully you'll be looking this way instead of down. One last thing I would like to ask you all to do, since we are about empowering women today, look 3 folks to your left, wave, introduce yourselves. Part of the point today, especially if you can't stay, is to meet your neighbors. I didn't make this easy. So, I am supposed to tell you that I have no conflicts of interest. I am employed part-time here at the university as an assistant adjunct clinical professor within UC Nursing, which is pretty interesting because I'm not a nurse, actually a recovering attorney, but really interested in women's health policy, women's health issues, the intersection between law and medicine. And that is how I came to co-found, along with several other really impressive women from UCI, the Orange County Women's Health Project. So those are my involvements, and we're going to dive in. The Affordable Care Act has many names, and I'm going to most likely refer to it today as the ACA. But we also hear it called the Obamacare, Healthcare Reform, the Affordable Care Act, the Patient Protection and Affordable Care Act. Lots of names for you to be aware of, and a link to the text of the law itself, in case you have any free time. Why are we living through this right now? Why is healthcare reform so important right now? Well, normally when I give this talk, no one in the audience has the benefit of my slides. So I kind of quiz the audience and I ask you all for some ideas. Why was it so important to actually make a move on healthcare reform?
Because there's so many uninsured Americans.
So many uninsured. Call it out, folks.
Cost. Yeah.
Costs.
People losing insurance that they've paid into for years when they finally get sick and need it.
Rescission of insurance.
The policy window and opportunity to finally actually do it.
Opportunity to finally do it. That's a very good point, yes. All of these reasons are in fact very true. Oh, and actually the picture, this was a free health and dental fair in Los Angeles. They do this every year. A variety of community clinics and volunteer healthcare professionals come together. This one was at the LA Sports Arena, and you only see a sliver. But thousands of people line up, sometimes sleep out the night before for free healthcare. And it's not just blood pressure, it's actual dental care, chronic disease management, enrollment in insurance and public insurance programs. The need was just overwhelming. It's truly stunning to look at the pictures from these types of health fairs. Here's how we were doing before the Affordable Care Act was implemented. The number of uninsured Americans was rising steadily. Over 10 million uninsured folks increased in just 10 years. It's simply astounding. And 20%, 1 out of 5 women in this country had no health insurance. And although we spent more, as you'll see, than any other peer in the industrialized world on healthcare, we had the worst outcomes, especially when it came to life expectancy and infant mortality, when we compare ourselves to our peers in the industrialized world. So we had an unsustainable system. We really couldn't afford not to act. On top of that, we had, and we actually still have, a mishmash, a hodgepodge of public and private insurance. It's very difficult to make sense of. There's no apples to apples comparisons. But in general, 3 big categories. We have the privately insured, the publicly insured, and the uninsured. And in this country, the public insurance programs that we're most familiar with are Medicaid, which is health insurance for very low-income individuals. In California, we call that Medi-Cal. Medicare, which is public health insurance for seniors, although I'm sure a few people in the audience might take issue with the definition of 65 as a senior. And in the private world, we have employer-based health care, we have the individual market, and of course, we have an uninsured population. And then prior to the implementation of the Affordable Care Act, the insurance industry itself had a lot of discriminatory practices built in. Not just discriminating against women, but discriminating against all classes of people. And by discriminatory, I don't necessarily mean a legal definition, something that's unlawful, but in certain cases that was in fact true, but practices that treated classes of people differently for not necessarily a rational reason, but this was institutionalized discrimination. And one of the things we'll be talking about today as one of the most horrendous examples was gender rating. And based on underwriting principles, women could be charged more than men for the very same benefit. We'll talk about that in a few minutes. So what is the big picture that I hope you take away today for yourselves as consumers? I assume that's why you're here, in part, maybe to learn a little bit about the policy, but also how do you as health consumers make sense of this law? And how can you use the information today to help navigate your own way in securing appropriate insurance? So from the consumer's perspective, there are 2 key themes. One is the expansion of health insurance. How do we bring more people into the insured system? And two is how do we reform some of these unfair and discriminatory practices that I was talking about earlier? So under the heading of expansion, first of all, we've redefined who is eligible for insurance and how we enroll. We've tried to simplify the process for enrolling, and we've tried to loosen the eligibility standards. Secondly, we've standardized the types of benefits that everyone is entitled to receive. And that simply was not the case before. And we've also expanded what is covered through various forms of health insurance. And finally, we've tried to make health insurance more affordable at the front end and at the back end. At the individual level for you all, as all of us as consumers, as well as for our country as a whole, how do we sustain the cost of healthcare? We're trying to reduce costs on both ends. Another significant reform in the private insurance world is that there is a massive shift towards prevention. And the reality was, for very low-income individuals and for ethnically diverse individuals, there are so many barriers to securing preventive care that often folks simply go without. And as a result, what could have been addressed at a very early stage as, an infection, high blood pressure, is not addressed until it's an acute emergency condition, which is far more expensive to treat and far more serious in terms of the health consequences of the condition. So we are having a very exciting paradigm shift in how we think about healthcare, not just treating collection of symptoms after they occur, but thinking more preventatively. Why is healthcare reform particularly important for women? I'm just going to ask you all, especially if you haven't cheated. Any thoughts?
Stay healthy.
Stay healthy.
Men don't need to stay healthy.
Take care of the family,
Family planning.
access to family planning.
Being a model for the family.
Being a model for the family, that's a good point. Women make healthcare decisions for their families. It's just that simple. It's very well documented. The health of a family tends to depend on the mother.
Women still earn less than men.
That is correct. Not only do they earn less than men, they tend not to have employer-based health insurance. They're maybe dependent with coverage, but because women tend to be in entry-level positions still, disproportionately in lower-paying entry-level positions, those are the types of positions that don't come with health insurance. Maybe they used to, not anymore. So women who don't have employer-based health insurance are left to fend for themselves in the individual market if they don't qualify for public insurance. And it's very difficult to find comprehensive coverage that's affordable in the individual market. Now, we in California are very fortunate because there are a lot of protections in place at the state level, but it's hard to fathom in many other states that you could not get maternity coverage as part of an individual plan before the Affordable Care Act, for example. It wasn't an option. Women pay more for insurance than men. I mentioned earlier, gender rating, women would be charged more for the same exact benefit. Women also spend a higher percentage of their household income than men do on their family's health insurance. And women do utilize the healthcare system more than men. They have greater healthcare needs. So there is some logic to why women have been charged more for the same benefits in the past. I don't mean to dismiss that, but we are trying to even the playing field. Women forego healthcare more than men. When forced to choose between food, basic needs, women are quicker to forego their own healthcare, not necessarily their children's, but their own healthcare when put in that position of having to choose. And finally, as I mentioned, gender discrimination was built into the insurance industry. So Affordable Care Act is really designed to help everyone, but there are unique benefits for women. Here's how it's supposed to work. So the idea is that everyone, with a few exceptions, ought to have coverage. Most people in the country have and would continue to have employer-based coverage when you get your health insurance as a benefit of employment. For folks who are very low income, and I'm going to talk about what that means in just a minute, we will qualify these folks for public health insurance, Medicaid, and we're actually making it easier to qualify for Medicaid. We're allowing people to qualify who earned a little bit more money today than they were allowed to earn yesterday. And then we've created the marketplaces, also called the exchanges. So imagine if you wanted to go buy a car, and you went to the Ford dealer, and you went to the Chevy dealer, you went to the Toyota dealer, and so on, and you wanted to line up and do an apples-to-apples comparison. Four-wheel drive, emissions, gas mileage, everything. Imagine if some website could put all that together for you as a matrix, a table, and compare apples to apples, your criteria, what matters to you, how each car stacks up on those various criteria, and how much it's going to cost. That is what the exchanges are trying to do. Create a one-stop shop where consumers, health consumers, can go online and see plans and compare them apples to apples. It's never been done before. If you've ever had to buy your own insurance, you really needed the help of a broker. It's very difficult to navigate and understand, especially comparing price what you're getting. So not only are we creating a marketplace, which is on the right side of the triangle here, but we're also introducing subsidies in the form of tax credits for folks who earn above the qualifying level for public insurance, up to about $94,000 for a family of four. So what we're effectively doing is helping out the middle class to buy health insurance if they don't get it through work. I don't think anyone in this room would consider $94,000 a low-income family, even in Orange County. And it's really a monumental shift in thinking about the importance of access to health care, that we are willing to subsidize the middle class in accessing health care. So we're creating exchanges for folks who don't get employer-based health care and who don't qualify for public insurance. We have expanded health insurance qualifications for very low income. We have employer-based health care, which is being reformed. And through all of these efforts, the idea is that everyone will have coverage, with a few exceptions. And I'll get into that in a moment. So where are we? I mentioned 1,389 days. That's where we are from the date of implementation. So far, we've seen the following milestone events. Young adults, one of the very first benefits to kick into action was that young adults, meaning adults up to age 26, could stay on their parents' plan. And this was a response to the reality of the recession, when so many students graduating from college or not able to even go to college in the first place were unable to get their first job. And if they did, it didn't come with health insurance. So not only were people being laid off, but young adults were simply not able to find meaningful employment with health insurance. So to address that population, we were able to put them on to their parents, and millions, I believe the latest count is that 3.1 million young adults have taken advantage of this so far. Have you all heard about this idea of pre-existing conditions? So the basic idea is if you have a medical condition that would have disqualified you in the past from being able to get health insurance, that is no longer allowed. That even people with some type of medical condition are still able to get insurance. And in implementing this change, we started with children. Children who had pre-existing medical condition were able to get insurance immediately upon implementation of the Affordable Care Act. It wasn't until this year, January 1, 2014, that the same was true for adults, and we're still figuring that out. Lots of other changes, milestone events. As many of you have probably heard, large employer having to come into compliance with the Affordable Care Act has been delayed for a year to allow for additional time. And then some of the remaining reforms for private insurance are subject to ongoing litigation, which we'll talk about. Any questions so far? Okay, so this is where we are. January 1, 2014 was a magical date. That was the date that all new policies offered through the exchange had to be in compliance with various reforms of the Affordable Care Act. Right now, people can't even get their insurance card numbers. So, you know, it remains to be seen how effective this implementation is at the early days. But the objective was that as of 1/1/14, almost all of the reforms in the Affordable Care Act were to be effective. So I talked a little bit about very low-income individuals being eligible for public health insurance, Medicaid, what we call Medi-Cal in California. What do I mean by that? The federal government has a definition. It's called the Federal Poverty Guidelines. It changes about every year or two. This definition is used by almost every social welfare program to determine eligibility. So if you earn under the federal poverty level or some percentage of the federal poverty level, then you are eligible for various benefits. That's when you hear the phrase FPL, federal poverty level, federal poverty guideline, that's what they're talking about. If you'd like to see how those change over time, there is a statutory reference at the bottom of the slide. But to put it in perspective, most families in this country are families of 3, single parent, 2 children. So I've highlighted it in orange. What does it mean to be at the poverty level in this country, earning under $19,530 a year? Now to put that in perspective, let's compare that to the minimum wage. The minimum wage, which is set to increase mid-2014, is nevertheless currently $8 an hour in California, $7.25 federally. So if you worked a 40-hour full-time job at the minimum wage, you would earn roughly $16,000. If you are supporting 2 children, you are under the federal poverty level. So our minimum wage doesn't even get you above the lowest of the low-income thresholds. To put it in perspective, you have to work at least 1.5 full-time jobs just to stay above the federal poverty level. Now I have a few other columns on this chart and the chart before, 138% and 400%. And those are very important. I'll explain why in a moment. But when I refer to 138% of the federal poverty level, you can always refer back to this slide, slide 10, to see where that falls based on the number of folks in the household. Okay? So if you want to figure out where you land in terms of what kind of insurance you qualify for in California, if you earn up to or including 138% of the federal poverty level, you qualify for Medicaid, which we call Medi-Cal. That's the public health insurance. If you earn between 139 and 399% of the federal poverty level, then you can purchase an individual plan on the exchange and receive a subsidy from the federal government in the form of a tax credit which is applied to your premium. Does that make sense? Okay. If you earn above 400% of the federal poverty level, you can still buy insurance on the exchange, but you will not be eligible for any kind of financial subsidy or tax credit. So anyone who needs to buy insurance on the open marketplace, on the exchange, can do so. The only differential is whether you qualify for a tax credit. And even though we now have this new marketplace called the exchange, also called the marketplace, which is regulated by the Affordable Care Act, and all plans sold on the exchange must comply with the requirements of the Affordable Care Act, there is still another market, the open market. You can still buy a plan off the exchange That's the language, off exchange or off marketplace. And most of the plans today, just so you know, are identical, whether they're sold on or off the exchange. That just is how it's working out right now. But theoretically, off-exchange plans are not subject to all of the regulations of the Affordable Care Act. They are subject to some, but not all. So in the universe of how you get insured, you either get public insurance, or if you get private insurance, you're either going to get through your employer, or you buy it yourself on or off the marketplace. And if you qualify for a subsidy, meaning if you earn between 139 and 400% of the federal poverty level, then you can apply that subsidy if you buy on the exchange. You can't use the subsidy for an off-exchange plan. Yes?
How does the subsidy work? How do you get that?
It comes with your tax filing. So actually, I'll show you at the very end. There's a wonderful resource online through what's called the Kaiser Family Foundation. It's a Northern California-based, independent, nonpartisan policy foundation. They've developed a tool called the Subsidy Calculator. The federal government's own healthcare reform website links you to this tool, and that calculator will help you determine what type and how much of a subsidy you would be eligible for based on the information you enter, and then you enter that information into the actual application. So when you are filling out your application, most people are going to be doing it online, but some folks will do it with a broker, some people may do it over the phone, and you can print it out and write it out and mail it in. There are mechanisms to help you calculate, and then it comes back to you in the form of a tax credit. It's complicated, to tell you the truth. There's part of the problem, part of the challenge in administering the tax credit is that if your income changes and changes the amount of the tax credit for which you are eligible, you have to affirmatively, proactively notify your exchange so that they can adjust. And if you don't do that, you might get dinged later with a tax bill. So that's going to be confusing. I think it's going to take a few years for people to figure out how to make it work. But it is in the form of a tax credit that's automatically applied to your premium at the time that you enroll.
And when you say off the exchange, you're talking about a private broker?
A private broker can actually help you apply on the exchange, but what I'm saying is there are plans that you can purchase going through, in California it's called Covered California. That's the name of our statewide marketplace or statewide exchange. You go to coveredca.com, you actually enter your information, and then you are applying through the exchange. But if you just went straight to Blue Shield, for example, you would be given the option of an on-exchange or an off-exchange plan. And right now, they're all looking identical.
I was just to say, what's the difference?
I think over time, there may start to be some differences, but right now, because everyone wants your business, they're all identical. But the main difference is an off-exchange plan is not going to be subject to all of the rules and regulations of the Affordable Care Act. So some of the insurance reforms that we're going to talk about a little later are not going to apply to off-exchange plans. And I also want to say this, Medicaid and Medicare, some of you may be interested in that personally, either for yourselves or people you know, also not subject to all of the regulatory changes brought about by the Affordable Care Act. Anything relating to Medicaid and Medicare has to be analyzed by a Medicaid expert or Medicare expert. You cannot make an assumption that because the Affordable Care Act made X change, that it applies across the board. So the changes I'm going to talk about today are changes to the private insurance market. Yes?
I'm just wondering, over time, what
Mhm.
do they think is going to happen in the difference between the opportunities?
I don't know, to tell you the truth. But there is a prediction that that most people will end up on the exchange. But it remains to be seen. It will depend in part on what happens with some of the legal and legislative challenges to the act. So the Affordable Care Act, as I mentioned earlier, two big takeaways for health consumers: expansion and fairness. So how is it that we're expanding the Affordable Care Act? Well, first of all, we're redefining who is eligible for coverage. So as I mentioned earlier, we're going to start with very low income population. That's folks below the federal poverty level. Well, it used to be that you could only earn up to 100% of the federal poverty level in order to qualify for Medicaid. Now you can earn up to 138%. It technically is 133%, but there's a strange formula. They use something called a modified adjusted gross income, which is a formula that effectively adds 5% to your household income to determine your eligibility. So for all intents and purposes, you may hear 133%, but the practical reality is you can earn up to 138% of the federal poverty level. That may not seem like a big jump, 38%, but when your income is $11,000 and you can move up to $13,000 for a single person, that's a big jump. You could see, for a single adult, childless adult, going from 11 to 15, actually, $1,000 and change is a big jump. So the first thing is, we're talking about expanding the Medicaid population. Now in Orange County, as of today, we've been able to move nearly 40,000 folks into Medi-Cal. We're a county of little over 3 million individuals. There were roughly 450,000 individuals in Orange County who were covered by Medi-Cal before, and we've just increased that. It's supposed to be 40,000. They're having some technical glitches. They're at 37,000 and change. They will get to 40,000 in a matter of weeks. That's a really big population for our community. The other really important change is that it used to be under Medicaid that you not only had to meet an income threshold, but you also had to meet a categorical qualification. You could only get Medicaid essentially if you were disabled, if you were a parent with dependent children, or if you qualified for certain forms of financial assistance as a disabled or elderly individual. So what that meant was single men and childless adults were not able to qualify even though they were the poorest of the poor. So this was a population that was completely neglected. What the Affordable Care Act has done is eliminate those categorical qualifications. The only question now is how much do you earn? So it's not only a lot easier to administer, but it's also a lot more expansive in its definition. And so we're bringing a lot of individuals into the publicly insured population. So it just makes it easier for the very low income folks to get insurance. This is a massive paradigm shift. By the way, I don't have a graph on this handy, but in California, we were pretty generous in our definition of how you could qualify for Medicaid. I mentioned earlier you could earn up to 100%. In some states, the cutoff was 16% of the federal poverty level. So if you earn more than, let's say, $3,500 and change, you were ineligible for Medicaid. Even though the federal government allowed you, by its own definition, to earn up to 100%, it was left to the states to decide what their cutoff was. So it's unbelievable how little you were allowed to earn to qualify for public health insurance. And you all probably know there was a Supreme Court case that upheld most of the Affordable Care Act. The one part of the Affordable Care Act that was struck down as being unconstitutional concerned the Medicaid expansion. And the act tried to mandate that all states participate in the expansion of eligibility for Medicaid. And if they didn't, then they would lose their funding for all of their Medicaid programming, not just the expansion population, but everything. And the Supreme Court said, you can't do that. If the states forego the expansion, they can only forego the funding for the expansion population. You can't strip them of all of their funding. So many states are still not participating in the expansion. So consider yourselves lucky to live in California, where we had a pretty progressive definition to begin with. And to show you where we are, the states in mustard, for lack of a better color, these are the states that are implementing the expansion. Blue, they are planning to move forward, but they're not ready yet. Dark orange, they are not moving forward this time. So these are states that are largely governed by either Republican governors or Republican legislatures or both. And usually it seems to me that as a matter of political principle, not necessarily practicality, but political principle or political reality, many of these states are simply refusing to participate in the expansion. The second area in terms of how or who is being brought into the mix is that the Affordable Care Act eliminates caps on coverage. So it used to be that when you bought an individual health insurance plan, you were capped out at $1 million or $2 million, either an annual cap or a lifetime cap. And by the way, not only did you lose your coverage for that year, but you were precluded from getting coverage in the future once you exhausted your lifetime cap. So these caps have been eliminated. There's no limit to your healthcare expenditures under the Affordable Care Act. Why does this matter? Because if you are hospitalized, if you have any kind of special orphan disease that requires really unusual treatment, if you have to take some kind of expensive medication, chemotherapy, you will very quickly exhaust your lifetime, let alone your annual cap. And most policies had these caps in place. So as of March of last year, 105 million people no longer have one of these limits. So we're talking massive numbers of people who have already benefited from the reforms of the Affordable Care Act. And by the way, this was true in the employer-based insurance market as well as the individual market. And finally, pre-existing conditions. This one has gotten a lot of traction because who do we know who has not one health problem at all, right? Everybody's got to do something going on in their lives, either themselves or in their immediate family. And there are, horror story after horror story of folks who were either dropped, someone over here mentioned earlier, dropped from their insurance policy midway through the year, having already paid all of their premiums because they got sick, or unable to get insurance after a significant disease, injury, illness, absolutely unable to get insurance. That is no longer allowed. Why does this matter? Because obviously anyone who's got a medical condition can now get insurance. And particularly for women, you wouldn't believe what counted as a pre-existing condition in many states. Basically being a woman was a pre-existing condition. If you have had a C-section, if you've had a miscarriage, if you've been pregnant, that would count as a pre-existing condition. If you were a survivor of domestic violence or a sexual assault, man or woman, that counted as a pre-existing condition. So it's hard to fathom, but this was a regular practice outside of California. So not only are we expanding who's covered, but as I mentioned, benefits and scope of coverage, we're expanding what is covered. And the Affordable Care Act has established a floor. There are 10 essential health benefits that must be covered in every plan sold on the exchange. This is radical. You don't get to buy a car knowing that you get 10 features, no matter which car you buy. 10 essential health benefits, and I've highlighted in orange those that have particular importance for women. Maternity and newborn care. As I mentioned earlier, in many states, you couldn't get health insurance that included maternity care, or you had to buy a rider that was cost prohibitive. And then we're going to talk at length about preventive and wellness services, particularly for women. But as you can see, this is a very exciting list and very comprehensive list of what we would like to consider basic health care. There's some catastrophic health care in there as well. But this is basic health care, and it ought to be covered. So, preventive health services. The government has decided that we're going to, how am I doing on time? Okay. That we want to be able to cover a variety of preventive health services. And how do we incentivize individuals to start taking advantage of preventive health care if they're not accustomed to doing so, if they don't go in for an annual well check, if they don't get a blood pressure reading, if they don't check their glucose, if they don't get immunizations or vaccines or flu shots on a regular basis because there's a $40 copay, there's an office visit charge, you get charged for the blood draw. If you just can't afford it, how do we now change people's mindset? We remove the copayment. We eliminate the cost barrier to incentivize individuals to start taking advantage of these very generous preventive health services. But which preventive services are going to be covered? Not every single thing that you could ever think of as preventive in nature, but there are 4 categories that are essentially those categories of services that well-established, highly regarded agencies and committees have blessed. So preventive services that have a high grade from what's called the U.S. Preventive Service Task Force. So this is the kind of gold standard agency that recommends women should get mammograms every 1 or 2 years after the age of, well, it's been 40, it's been 50, but this is the agency that sets those standards. Immunizations that are recommended by yet another agency. Preventive care for children, so vaccines, immunizations, children's annual checks. And then there was a special category carved out for women's preventive health services because finally someone, it was actually Senator Barbara Mikulski, made a point of carving out preventive health services for women because of the unique health needs of women. So what do these preventive health services include? Well, this is the subject of ongoing controversy. And we're going to talk about that in a moment. But right now, there are 8 categories of women's preventive health services that you can take advantage of and not be charged a copayment or have it apply to your deductible. So you might hear people say these are free preventive health services. They're not really free because you're still paying a premium. And your premium is being used to cover these services. They're not really free, but you're not being charged anything else. Does that make sense? Yes?
Doesn't your premium become higher if there was a copay?
Well,
Because that happens to me.
you know, there's a lot of reasons why premiums are going up initially, and for as many premiums that are going up, there are also at least the same number of premiums going down. The idea is that by spreading the risk and spreading the cost of all of these services that now everyone gets without a copay, we will have to build them into premiums. But we are also trying to pay for these increased costs of healthcare through other mechanisms, like a tax on medical devices, which is very controversial, especially here in Orange County, because we have so many biomed companies, and this is a big part of our economy here in Orange County. It's a very serious tax. That is, the funds are supposed to be used to help pay for the Affordable Care Act, increased benefits. The idea of bringing young people in, historically, young people didn't always buy insurance if they didn't get it at work because they think they don't get sick, they don't go to the doctor, they'll just pay as they go and self-insure. Now we're requiring everyone to buy health insurance if they don't get it at work and if they don't get it through a public health insurance. The idea is we bring in this group called the Young Invincibles, young, healthy folks, require them to pay. They're not going to use as much as they pay in. So that will subsidize all these additional benefits and the higher users of healthcare. So there are a lot of different mechanisms for paying for these increased benefits. Is that the direct reason why your premium went up? I can't say if it's the only reason or the direct reason, but it's probably one reason. One of the things to be mindful of, because this is an issue that we're hearing a lot about and many of you in the room may be affected by. You know, your plan was canceled, you had to go get another plan, and you're now paying more. One of the things to try and keep in mind is, because we're living through this ourselves, is that we may be paying more, but we're getting a lot more. And at the end of the year, if you're so inclined to try and actually calculate, if you track it year long, how many things you got that you didn't pay for, that you used to have to pay for, and build that into your cost comparison, you might be pleasantly surprised. And there are some economists who are doing this kind of analysis right now to demonstrate that although it may appear at first blush that you're paying more, not only are you paying more and getting more, but actually you're going to pay less by the end of the year. And if you haven't factored in the possibility of getting a subsidy, that can dramatically change your out-of-pocket costs. So we could talk about more afterwards and see if you might have any other options. Yes?
But, and maybe I don't quite understand this, but isn't it true that men and women are paying the same? I mean,
Yes.
a man and a woman who make the same amount, are the same age, pay the same insurance more. choose the same insurance would pay the same amount.
That is correct.
So in that sense, these benefits are being also subsidized
by men. Absolutely.
who used to not pay as much.
That's right.
Even though they were involved in making that baby too.
That's right.
And it's just the fact that
They had a mother at some point.
breastfeed.
That's right. That's right. We're now redistributing the cost. We're redistributing the risk. You know, the Affordable Care Act, the whole separate lecture, which I would be interested in attending, not giving, is about how we pay for it and the economic mechanisms at work. Anyway, let me just go through these because this is really where the biggest bang for the buck is in terms of women's health. We're taking basic women's health care that we all think of, and we are all probably wondering, duh, why didn't we think of it this way before? And now treating it as basic women's health care. It's preventive. A well woman's exam. When you go in to see your OBGYN or your clinic, once a year, you get the top to bottom, your pap smear, family planning advice, cancer screenings, and so on. This is now all covered as a preventive health service. The visit, the tests, even your prescription birth control. Screening for gestational diabetes, HPV DNA testing. HPV is a sexually transmitted disease that is probably the most prevalent in the world, and it causes almost all forms of cervical cancer. And we now have a vaccine for HPV, which is essentially a cervical cancer vaccine. First cancer vaccine for women, essentially. And one of the tests that can be helpful is an HPV DNA test, and that's now covered. Counseling for sexually transmitted infections and for HIV. What we're hearing the most about, and certainly what's the subject of the news right now because of the Supreme Court cases, contraceptive coverage. I'm going to talk about that in a little more detail. Breastfeeding support and supplies. This is a monumental shift in thinking. That having access to breastfeeding support in the form of counseling and access to supplies without cost sharing should be covered. It really empowers women to be able to breastfeed if they are so inclined, by removing that cost barrier. And then another really significant expansion is that we are now covering when a healthcare provider screens a woman for domestic violence as part of a healthcare visit. It's a new way of thinking about domestic violence, a new way of thinking about healthcare, is trying to appreciate the intersection between the two. Yes?
I know you're speaking about the women's preventive care, but on that point, does it also go toward domestic violence that affects men or elder abuse? Do you know if that's built in?
It's a good question. These 8 categories of preventive health services to be covered without cost sharing are specifically for women patients. The panel that was convened to do the research and make a recommendation was specifically tasked with making recommendations for women's health services. So if it's a female elderly patient who might be the subject of elder abuse, then it would be covered. Certainly, family violence directed at men or children is a very significant issue in our society. This child abuse screening might fall under a covered benefit under another type of preventive service, not a women's preventive service, but screening men, at this point, not covered. Yes?
The screening for domestic violence for women, was that previously the patient had to pay for it, or did the insurance just not pay the physician for it?
It's actually a good question with a multi-step answer. First of all, a lot of physicians just aren't doing it to begin with because they didn't see it as their role, they didn't understand the relationship between domestic violence and health. They didn't know how to screen. There's an art to it. There's a growing body of literature about the kinds of questions to ask, how and when and where to ask the questions, and what to do if someone actually screens positive and says, yes, I am feeling unsafe at home. Yes, I have been hit by my partner. What to do with that information. That scares a lot of healthcare providers. So A, it wasn't really being done as a matter of course. B, there was no specific way of coding for that time. And so even if it had been done, it wasn't necessarily being reimbursed. We're still trying to figure out what the appropriate coding mechanism is to ensure that the time spent screening and counseling is reimbursable time. Under this mechanism, under this framework, it has to be reimbursed time, but we don't have a mechanism for it yet. It's something that's actually being worked on at the national level. So I don't expect you to actually be able to read this. I put it up simply to show the unbelievable array of preventive services for men and women now covered without cost sharing. So remember there were the 4 categories: grade A and B USPSTF, vaccines and immunizations, special programs for children, special programs for women. When you put them all together, this is what we're looking at. The ones in orange are the women's preventive health services, unique to women. But this is an unbelievable array of services available to men and women that really ought to change our behavior. You know, I heard a lecture last year here. Someone came from the public health department and made a really interesting comment that in the 20th century, the whole model of public health was based on the idea of containing communicable disease. The greatest public health threat was contagion. In the 21st century, the greatest public health threat is behavioral health. Chronic disease. How do we eat? How do we exercise? Do we smoke? Do we use or abuse substances? We're not as concerned today as we used to be about tuberculosis, although polio, for example, we're seeing a resurgence in polio, and these are issues that are still very much present, but they don't dominate the public discourse about public health and how do we contain the healthcare costs in this country. What's really at stake is our behavior and how it affects our health. So these services are all intended to change our behavior in a positive way. And by removing the cost barrier, particularly for women, we ought to see some really wonderful results over the long term. We're not going to see this tomorrow. But over the long term, if we address at the front end instead of the back end, we will rein in the cost of healthcare. And as I mentioned earlier, this is just a reminder, just because it's true for private insurance doesn't mean it's true for Medicaid and Medicare. So as I mentioned, there are these reforms at work right now. We're ending gender rating, and to put it in perspective, 42 states, not including California, allowed individual plans to charge women higher premiums than men for the same coverage, as much as 84% more. Why does this matter? A 40-year-old non-smoking woman could be charged up to 63% more than a 40-year-old male smoker. I mean, this was the reality outside of California. Another really, well, let me say this as a summary. We're making health insurance more affordable for women. We have gender-neutral changes that benefit women disproportionately in a good way. Okay, so these are changes that are available to everyone, but women stand to benefit even more than men. We're expanding eligibility for Medicaid because women earn less than men, because women tend not to have employer-based health care, because women spend more of their household income on health insurance and health care expenses. Women are going to benefit more from the expansion of Medicaid. More women are going to move into Medicaid. Subsidies for private insurance. This will disproportionately benefit women. Requiring large employers, if you employ more than 50 employees, and by the way, you could have 100 part-time employees, but if you add up their hours, you got 50 full-timers. So it's not the label, it's the amount of time that they're working. Yes. So you got to be careful how you count. But you employ more than 50 employees, you are now required by law to provide health insurance, or you have to at least provide a subsidy to your employees to buy health insurance on the marketplace. And that will disproportionately affect women positively because women tended to be excluded from employer-based health insurance. And then finally, I don't know if you're aware of this, but there is also a maximum amount of money that you are able to spend under a private insurance plan. It used to be no limit at all. Now, the most you can spend is $63.50 for individuals and $12.7 for a family. That is your maximum out of pocket for the year. It's a lot of money, but at least there's a cap. And then, as I mentioned, the preventive health services with no cost sharing. This will disproportionately benefit women in a positive way. And then, of course, well, what are the gender specific? What are the changes that are really only for women? The women's preventive health services. And yes?
What percentage of the marketplace insurance, or excuse me, what percentage of the employer-based or private insurance is marketplace? Is a marketplace exchange?
I don't know, but I have a slide that talks a little bit about the breakdown for women a little later. It may help illuminate that, but see me afterwards and we can follow up.
Yeah.
We're eliminating gender rating. We're prohibiting denials based on pre-existing conditions, such as surviving domestic violence or having had a C-section. Maternity care is now covered. By the way, when I say that you couldn't get maternity coverage in the past, literally only 13% of plans in the country offered maternity care before the Affordable Care Act. 13%. And then the inclusion of women's preventive health services. This is just a quick summary of all the different ways in which women's health will improve thanks to the Affordable Care Act. So, what does this really mean? What do the numbers look like? So there was a recent analysis done the end of 2012. If all the states were to participate, and if all the plans that are offered on the exchange are in fact affordable. Now these are two really big ifs, but this is kind of the theoretical, how is it supposed to work? There are 98 million women who are in the United States who are 18 to 64. So this is the market for insurance, because if you're over 64, you're in Medicare. If you're under 18, then you're either a dependent on your parents or you qualify for the Children's Health Insurance Plan. So when we talk about how many women are we really talking about in this country, it's roughly 98 million women, okay? 58% get employer-based coverage. 20% are uninsured. Remember earlier I said 1 in 5 women uninsured before the Affordable Care Act. 12% covered under Medicaid, 7% by their own individual plans, and then 4% have other. It could be Medicare, military-related, tribal, etc. Okay? Of those 20% who are uninsured, it's estimated that 90% will qualify for coverage, either through the expanded Medicaid or being able to afford insurance for the first time ever, probably because of subsidy. So here it is graphically illustrated. Of that 20%, the darkest blue section of the pie, the estimate is that 53%, okay, so the 20% represents roughly, 17 million women who are now going to get coverage. And if you think back to the early discussions about the Affordable Care Act, the number that was being thrown around was 30 million people. We're going to bring 30 million people into the system. Of those 30, 17 million are women. And of those 17 million, 53% are going to move into Medicaid. 37% are going to qualify for a subsidy on the exchange. And then 10% will be able to buy insurance. They won't get a subsidy, but maybe they had a pre-existing medical condition and weren't able to buy insurance before, but at least now they qualify. So this is a massive number of women we are moving into coverage. And this demonstrates where we ought to be if the Affordable Care Act is fully implemented. So the number of states where fewer than 7% of women are uninsured will dramatically decrease, as you can see on these two maps. How are we doing so far since we implemented? I've just given you some projections. Here are some actual numbers. As of March of last year, the Department of Health and Human Services estimates that 71 million Americans have received expanded coverage of one or more preventive health services. So you remember that slide where I had 60-some preventive services in various columns? Now we're talking about 71 million folks have been able to take advantage, including nearly 27 million women. And in California, we make up 8 of the 71 million Americans. And of that, almost 3 million women taking advantage of preventive services so far. This was as of almost a year ago. So what is it you're hearing all the noise about right now? There's a Supreme Court case in the making, contraceptive coverage. First of all, have you all been hearing about this? Hobby Lobby? Okay, I'm going to give you a quick tee-up. So under those 8 categories of women's preventive health services, the one that seems to be getting the most attention is this. All FDA-approved forms of birth control for women are to be covered with no cost sharing, prescription birth control. So instead of having to pay your $40 for your pill or $100 some for your IUD insertion, it's the actual device or the medication, the visit that's required to either insert the device, it could be an implantable device, it could be hormonal device, it could be the counseling, the visit, the device itself, or the medication itself. It's all covered with no cost sharing. So again, it's not free because you're paying for it through your premium, but there's no additional cost. It doesn't count against your deductible, and you don't get charged a copay. All FDA forms of contraception are now to be covered. If an employer refuses to provide that contraceptive benefit in its insurance plan, it will be fined. Many employers are objecting because they find the required provision of contraception to be against their religious or moral beliefs. The government, from the very beginning, established a special exemption. If you are a religious organization, you have a tax treatment as a religious organization, special IRS treatment, meaning you've already filed, and your actual purpose is to inculcate religion. So essentially we're talking about the church, the temple, the mosque, then you are exempt. You don't have to provide coverage for contraception in your plan. Then the Obama administration, this all went into effect in 2012. And there was so much uproar about this that the Obama administration said, you know what, we're going to create a year safe harbor, let's figure this out, we're going to take public testimony, comments, and let's hear what all the complaints are and see if we can work this out. So in that time, the Obama administration issued some rules and created a special accommodation for a second class of companies. So we already have the church, and I use that, to encompass all religious organizations, houses of worship. The second class are nonprofit, religiously affiliated organizations, like a Catholic-owned and operated hospital, or a Jesuit school. So it's a religiously affiliated organization. The purpose is not to inculcate religion, but they're nonprofit, and they operate in a manner that's consistent with their faith. This group is eligible for an accommodation under the current rules. If they fill out a piece of paper and certify, we're a nonprofit organization, we're religiously affiliated, and we object because the provision of birth control contradicts our religious and moral beliefs, then employees of those organizations are free to go directly to the insurance company for their contraceptive benefit. What it means is that the employer doesn't have to be involved, but the employees still have access to this benefit, which is covered, FDA-approved forms of birth control with no cost sharing. That's the second category. The third category is everyone else, and that includes for-profit companies that are owned by private individuals or other organizations that do not have a nonprofit or religious purpose. But within that category, we have a number of organizations that are owned and operated by individuals who are operating their business according to their faith. And they are objecting as well. And there's no special accommodation or exemption. So we have these 3 different classes of employers. There are 90+ lawsuits pending right now challenging this requirement and these various rules, the different ways of slicing and dicing employers. And the Supreme Court just agreed to hear 2 cases, 1 hearing March 25th. It was just set. And the question raised is this. The plaintiffs are 2 for-profit employers. So this is the third category. One is called Hobby Lobby. It's a national chain of craft stores. The other is called Conestoga Wood Cabinets. It's a Mennonite-owned company. They make cabinets. Hobby Lobby is, I believe, Presbyterian. And they both operate their businesses in a manner that's consistent with their faith. Hobby Lobby, they hold themselves out as a Christian company. They are closed on Sundays. They only play Christian music. They won't sell anything they find objectionable, whether it's music, media, t-shirts with slogans, anything that they consider to be objectionable under their faith. Conestoga Wood, I don't actually know the details of the way in which they practice their business consistent with their faith, but the question is not whether they're authentic in their observance. The question is, can a for-profit company exercise religion? Does a for-profit company have the right to religious expression, and should it qualify for an exemption or an accommodation under the law? And it raises questions under both the First Amendment, we have a right to religious exercise, and it also raises questions under a statute called the Religious Freedom Restoration Act, RFRA. So now you are hopefully somewhat familiar with what you're going to be hearing about in the news. And there was another case that's not really at the Supreme Court yet, but just a couple of days ago. Have y'all heard about the nuns? Okay, so the Little Sisters of Mercy actually fall into the second category. So the two cases that are currently going to be heard by the Supreme Court, for-profit employers owned by individuals claiming that their corporation should be entitled to religious expression. And by the way, if you just to understand how this could possibly have gotten to this point, there was a case a few years ago called Citizens United, which was the first time the Supreme Court recognized that a corporation could exercise free speech rights under the First Amendment. So they're now arguing that the logical extension is that if a corporation has First Amendment speech rights, a corporation should also have First Amendment religious rights. Back to the nuns. So the Little Sisters of Mercy operate a ministry supporting, 70 disabled and elderly patients. They are a religiously affiliated nonprofit organization. Interestingly, the insurance that they carry is also a Catholic insurance company that doesn't provide birth control coverage in the first place. P.S., that's actually exempt. So houses of worship and Catholic insurance companies or houses of worship's owned insurance companies are exempt from the provision, which is why this is kind of a strange case that's getting a lot of attention. But the nuns refused to sign that. Remember I said you have to sign a piece of paper in which you're certifying we're a nonprofit, we're affiliated with this religion, and this is objectionable to us, so we want nothing to do with it, and we are requesting an accommodation, and our employees can go straight to the insurance company to get their benefit, but we want nothing to do with it, and we will not pay for it. That is the way the system is supposed to work. The nuns are saying, we won't even sign the piece of paper, because all we would be doing is authorizing someone else to sin on our behalf. And we can't be a party to it. And if you don't understand that, you're missing the whole point. That's what their argument is that we can't be a party to it whether we are actively providing the insurance or whether we are facilitating by signing the paper. Now the argument in response is, A, you're just way too many steps removed to be arguing that this is about your religious exercise, nuns. You're not seeking contraception. You're not doing anything but signing a piece of paper, just like a conscientious objector has to sign a declaration that they are of XYZ belief and that they object and therefore should be exempt from the draft. That person, theoretically, by gaining an exemption, is authorizing the government to draft someone else in their place. So they're facilitating that to which they object. So it's a really interesting, complicated argument, which I haven't even gotten to. The other perspective is this isn't about religious exercise, this is about healthcare, folks. And health insurance is compensation, and just like my employer can't tell me how to spend my paycheck, my employer can't tell me what kind of healthcare I can use. So a lot of different interesting perspectives on these cases. Not clear at all how the Supreme Court is going to come down. There's no way to predict this, especially because it was Chief Justice Roberts who wrote the opinion upholding the Affordable Care Act. No one in a million years would have predicted that. So there's simply no way. And by the way, the reason we have heard about the nuns is because last week, I didn't even know you could do this. Are there law students or lawyers in the room? Besides, I know over here. Okay, the nuns actually somehow got before the Supreme Court with a special request for what's called an injunction, which is an order that essentially preserves the status quo. And the injunction was issued by one Supreme Court justice. I'm a lawyer, I didn't even know you could do this. For under certain special circumstances, while a case is pending in the federal appeals court, you can ask the Supreme Court for an order staying or enjoining the law from taking effect while you're trying to work through the litigation itself. So the nuns were able to get an injunction from Justice Sotomayor, who would have ever predicted Sotomayor would have been the one to grant an injunction based on her political background. And they were able to successfully get an injunction which orders the appeals court to essentially exempt the nuns from having to comply with the requirement while the litigation is pending. Usually, you're only willing to grant that injunction if you believe that there's some merit to the case and there's a likelihood that they're going to win. So we have no way of knowing where this is going to go, so stay tuned. Anyway, I've got to wrap it up. I've just gone through the legal challenges, and I did want to mention one thing in case you have questions, because this is obviously another women's health issue. The Affordable Care Act does nothing to change coverage of abortion. So the rule in this country is that federal funds cannot be used to pay for for abortions, except in the cases of rape, incest, or where the mother's life is in danger. Now, states are free to use their own funds to cover abortions more expansively than what the federal law allows, but any federal funds, and that includes tax credits, cannot be used to cover abortions. The Affordable Care Act does not change that, and in fact, it specifically states that abortion cannot be an essential health benefit, those 10 categories of standard benefits. Okay? Interestingly, states are actually allowed, under the law, to pass laws that specifically prohibit insurance companies from offering abortion coverage. And 24 states have done that so far. So if you're interested in learning more about the exchange, it's covercalifornia.com. You can evaluate plans, you can apply, you can enroll, you can do that subsidy calculator. This is what it looks like, the front page. It's a very user-friendly website. And just to show you, if you live in the UCA Irvine area, here is these are examples of the types of subsidies for which you would be eligible based on your family size and how much you earn. These are terrific resources if you'd like to learn more about the Affordable Care Act. Cover California is our state exchange. Healthcare.gov is the federal website. It's the federal exchange and the federal website. So for states that are not operating their own exchanges, the federal government is operating an exchange. So you can get all kinds of information there. Kaiser Family Foundation, the subsidy calculator. And for anyone who really wants to, in very simple terms, learn more about how this is all supposed to work, there's a fabulous animation called the U-Tunes Get Ready for Obamacare. So this is what you send to your kids, your great aunt, your friends that you like to debate the merits of Obamacare with. This really sets it out in plain language. Cancel plans we talked about. And I'm just going to stop it there and make sure we have some time for questions or discussion, and I will stay afterwards. So thank you for your attention.
Thank you so much, Allyson. I just wanted to present you with a little gift as a thank you. And I also want to thank our team of people here, including Cindy and Karina and Jess and Jennifer and Edgar, for helping us to set all of this up today. We couldn't have done it without them. And there's some other people like Kelly, who's not here, and Jessica's in the back. So thanks to all of you. And Allyson said she'd be here for questions. I know some of you may have to go back to the office. If you don't, please feel free to stick around. We'll all be here for just a little bit. So thank you again.
Thank you.
Thank you.